Hello, I'm Nora Hanna, Chief Engagement Officer at Sun Health, and I'd like to welcome you to this episode of Coffee Connections. We created this series to help you stay connected to the latest developments in healthcare and wellness by hearing directly from experts in our community. The Sun Health Foundation is committed to ensuring that this region has access to the most recent medical and technological advancements, and that we attract the brightest and best practitioners for care. To that end, we are the exclusive philanthropic partner to Banner Boswell and Banner Del E. Webb Medical Centers. Our mission is to empower others to live longer, healthier, and more purposeful lives. So we're excited to be able to offer you this unique access to these valuable expert resources. Thank you for joining us and enjoy the presentation.
Good morning. Good morning. Thanks for joining us today. I know we have a slightly smaller than usual group, and let me tell you why. Oh, by the way, I'm Nora Hanna. I'm the Chief Engagement Officer at Sun Health, which means I bring the community into Sun Health. I oversee the foundation. We have amazing foundation employees here. Raise your hands. Yes, they get up early in the morning to set up for events like this and pick up the food. And yeah, it's a tough, demanding, and very rewarding job because we get to meet with people like you and be out in the community. I also oversee our branding and our marketing, and so everything that's sort of outward facing. But enough about me. The reason we're here today are multifaceted. One is Sun Health has been doing these coffee connections for years, but we're really trying to expand our reach into the Southeast Valley. And it's been a challenge, I will tell you, Southwest Valley, because we have been, a little bit of our history, and many of you may already know this, but Sun Health was born first as a foundation. We raised the money 60 years ago to build the Boswell Hospital because there was not access to acute care in Sun City. You couldn't even get an ambulance to come to Sun City to take you to Youngtown or to Central Phoenix, which was the nearest hospital. So problem to be solved. And we stand on the shoulders of these amazing residents of Sun City who got together, which is hard for me to fathom, sat around a table and said, we need a hospital. What are we going to do about it? And they literally went door to door, had one of these big thermometers at the entrance to Sun City, like, we need to raise this much money to build a hospital. And they did it. They opened the hospital. They were very successful in how they managed the hospital, which was with a lot of volunteers. And then they built the Del Webb Hospital as well in Sun City West. And also they were really on the vanguard. We were really on the vanguard of preventive health in the launching of the Sun Health Alzheimer's Research Institute, which many of you are aware of, and we're celebrating 40 years. So think about that, really thinking about, how do we get to root causes and not just deal with issues after they're already presented to us in our physical health. So we've been working in that community and in that area for a very long time. It's been a part of our mission. And our mission hasn't really changed, but over the years, we have put the hospitals very smartly in a merger with Banner, because that gave us a much broader network of resources, including with MD Anderson, as you're going to hear about more today. So it added so much to our ability. And then we also, as many of you know, and I think some of you, how many of you live in a Sun Health community? Awesome. So many of you know, within the communities themselves, we work really hard to ensure that our residents have healthy longevity. All of us want to live longer, but you don't really want to live longer if you can't do any of the things you want to do, if you don't have your physical health, your cognitive health, and your social and emotional health. So we're really trying to ensure that that's a big part of what we offer, not only our residents, but to the community at large. So that's a little bit about Sun Health. The foundation itself is the chief philanthropic. We should take this out of my remarks because I can never get this word out. Chief philanthropic partner, and I think if we can go to the next slide. Oh, I'm supposed to be running my own slides, aren't I? Chief philanthropic partner for the 2 hospitals. And we also do a lot of fundraising for the Research Institute as well. So we work really hard to meet the needs. You know, these hospitals can't operate without philanthropy. As much as your insurance or your copay or whatever it is may cost you, it does not even come close to covering what needs to happen to give the quality of care that we offer in these 2 hospitals. In particular, these are some of the things that we have been raising money for over the last couple of years. We'll have some new initiatives coming up for the next 2 years. But many of people said, you know, I don't really care about obstetrics. But you should. And let me tell you why. The big shortage that we're seeing nationally is in healthcare workers. And healthcare workers are having babies. So in order for them to be drawn to our community, we really need to provide the resources and services that they need to ensure that we have that support going forward. So really important that we keep that facility. It's booming. There are a lot of babies being born there. I remember when they first opened it, everyone was like, wait a minute, we're putting a birthing facility in Sun City West? Yes, but it's been a phenomenal resource to the community at large. And then at the Boswell Center, hopefully you've heard about this because we have done a lot there. In our G4G campaign, we sort of did a overhaul of Boswell. And it was a $48 million project that we raised money for to do that. And Boswell looks phenomenal today. But the big thing we've done is this revamp and renovation and expansion of the endoscopy suite, which allows people to get in and out of the hospital much quicker and serve patients. And you know, it says, well, you know, would it be nice to get out faster? Yes, but the key is, I know we've all experienced this. They're like, oh, you know, you need to have this done, and we can get you in 3 months. And you're like, wait, I need this now. Well, expanding this suite allows these physicians to treat people more quickly and move them forward more quickly so that, you know, your time to get in gets compressed as well. So we're all affected by this, whether it's, you know, now or down the road. It's very important to what we do. So we did a big tour and a ribbon cutting of the IR suite. It's quite phenomenal, and the practice there is exceptional. So today you're going to hear from one of our favorites, Dr. Wakwe, and I want to make sure I give him the appropriate. Did you grow up in Atlanta?
No, Little Rock, Arkansas.
Little Rock, Arkansas, because he went to Vanderbilt Medical School and then did your residency at Emory. Yeah, very impressive. But what I really liked about his bio, which of course I will never do justice to, is he's committed to delivering patient-centered care with a strong emphasis on clear communication, shared decision-making, and optimal surgical outcomes. And you know, that's, if you ever hear a complaint about a doctor, it's about their bedside manner and how they weren't partners with you and didn't give you enough communication. So that really resonated with me. So I'll read this because I'll never get it right. He specializes in the treatment of both benign and malignant diseases of the esophagus, lungs, diaphragm, mediastinum. You would not have known that here. And chest wall, with a focus on conditions such as esophageal and lung cancer, GERD. We've already raised our hands as this is one of our problems. Hiatal hernias, diaphragm paralysis, and chest wall tumors. And with that, I'm just going to turn it over to you, Dr. Wakwe. We're so thrilled to have you here.
Thank you so much, Nora. I really appreciate that introduction. That was awesome. Thank you guys for having me here. I really, really appreciate it. Thank you to the Sun Health Foundation, the Southwest Arizona community. Thank you. I really appreciate it. I've done a couple of these coffee connections before, and they've always been very enlightening. I've always had great questions. I've always enjoyed it and meeting and discussing these topics. So thank you for having me again. Okay. So this Coffee Connection. Oh, first of all, I'd like to say, definitely I echo exactly what Nora mentioned as far as the IR and particularly the endoscopy suite expansion at Boswell. That's where I primarily work at, and it's a top of the line expansion. Thank you, Sun Health, for that. And even just this morning at 7:30, I added on a case. And they were able to fit me right in because we have more rooms, more staff, and more availability to do these cases a lot sooner, a lot faster. It's helpful for the patient, but it's also helpful for me. Get to go home a little sooner now. So thank you, I appreciate it. All right, so this is a topic I want to talk about, esophageal cancer. Cancer is never a great topic to talk about sometimes. Sometimes we want to, not touch on it, but it's very, very important to touch on it because there's some things sometimes that you may be able to recognize, may be able to detect a lot sooner so that you can get this treated and hopefully cured, okay? It is still here. We want to get rid of cancer. We still have a lot of work to do, but it's something that we have to contend with currently, and we need to know about it in order to contend with it, okay? So this particular topic is esophageal cancer. It's rare, but certainly a cancer that I deal with and I specialize in, if you will. So I want to talk about esophageal cancer, the silent threat. Great. So just an agenda slide talking about what I want to discuss, and these are key topics that will be separated as we go through this discussion. And I have some questions throughout the presentation, just so that we can have some engagement and some thoughts. But ultimately, hopefully, this will help you in remembering some key points about this discussion, and then we can discuss afterwards as well too if you have any further questions. So first of all, what is esophageal cancer? I want to discuss key facts and statistics regarding this. The diagnosis, so the signs and the symptoms associated, particularly with esophageal cancer, as well as some imaging that typically are used in order to help diagnose it. And then ultimately the stage, essentially how advanced is this tumor, and then some of the treatment, and then also some advances in the treatment. So esophageal cancer, what is it? First question I have, right off the bat. Where is the esophagus located? And you can just throw out some answers if you like, or I'll have to point out some folks. I don't want to have to do that. And so, 4 options. It's either in the chest, is it in the neck, in the abdomen, or all of the above?
All of the above.
Wow, you guys are good. You are correct. It is all of the above. The esophagus is a unique organ. One of the initial parts of the GI tract is the esophagus, and it spans essentially 3 fields, if you will: neck, chest, abdomen. So just here, this here is just kind of showing a kind of a crude diagram of the GI tract. Esophagus, again, one of the initial organs of the GI tract, and of course it connects to the mouth, and then ultimately connects to the stomach, which is in the abdominal cavity. But you have the GI tract, the esophagus that spans all 3 of those areas. So it's a hollow muscular tube, and it's, like I said, located between the spine and the trachea. It's only about a foot long, okay? And there are portions of the esophagus that are narrow and portions that are wider. So the most narrowest part is about 3/4 of an inch wide. And then, as I mentioned, spans those 3 fields. So just different parts of the esophagus. So the first part is called the upper esophageal sphincter, or the UES. And it's really just a muscular ring that allows the esophagus to open, particularly when you initiate your swallowing complex. The lumen, and these are some terms that may be used throughout the presentation, so I want to define them. The lumen of the esophagus, essentially, because it's a hollow muscular tube, The inner portion of the esophagus is called the lumen, and this is essentially where the food and the liquid travel through the inside of the esophagus after you swallow. Next, we call the gastroesophageal junction, or the GE junction, and it's an area of transition from the lower esophagus to the stomach. And this is where the lower esophageal sphincter lies. And then you have the LES, or lower esophageal sphincter, and that again, similar to the UES, is a muscular ring at the end of the esophagus, and that controls the amount or the rate of emptying of the esophagus into the stomach. And this is an area that hopefully, if functional, can limit the acid exposure into the esophagus. And this is, quite frankly, one of the reasons people can develop reflux or acid reflux disease is if you have some dysfunction of this sphincter. So a little bit more about the esophagus and esophageal cancer. Esophageal cancer can occur anywhere along the course of the esophagus, but typically it does start off in the innermost layer of the esophagus, and then it grows outward in a radial fashion. So here, just kind of showing the esophagus here, and then the cross-cut is here, and essentially the esophagus has multiple layers here. And the inner layer, as I mentioned, or the inner tube, is the lumen of the esophagus where food and liquid go through. And then esophageal cancer will start particularly from the inner layer, so you have disruption or abnormality of the cells here, and as it grows outward in outward fashion. Okay, and this is just kind of discussing some of the more in-depth terminology for the layers of the esophagus. So, let's skip one. Okay. So, types of esophageal cancer. There are two main types, and depending on where you are in the world, one is more common or prevalent than the other. So, it's squamous cell cancer or adenocarcinoma. Squamous cell cancer particularly is found in the upper and mid portion of the esophagus. Adenocarcinoma is now become the most common type of esophageal cancer here in the Western Hemisphere, particularly in America. And then there are other more rare types. You can have lymphoma of the esophagus, you can have melanoma of the esophagus, you can have sarcoma of the esophagus, and you can have a very, very aggressive variant neuroendocrine cell esophageal cancer. And this here is just kind of showing you the esophagus, so upper and mid esophagus here, more commonly squamous cell carcinomas, and then the lower esophagus here, lower esophagus and what we call the GE junction. So GE junction tumors can be here as well. More prevalence of adenocarcinoma in this area. And this here is just showing you, as I mentioned, cancer typically starts from that inner layer, see the abnormality in the cells here, and then it grows outward towards the surrounding tissue. So again, a little more esophageal cancer. So as I mentioned, squamous cell cancer starts from this part of the starts in the part of the mucosa that's limited with just the squamous cells, and that tends to be the upper and mid portion of the esophagus. This is usually located in the cervical and the upper thoracic and the mid chest region, and this is the most common type worldwide, but not as common in the U.S. Now, as adenocarcinoma starts with the glandular cells, usually the cells that make mucus. This is located in the lower esophagus. Often starts out with what we call a precancerous condition. And this is called Barrett's esophagus. You may have heard of it. And this is a condition that we have irregularity in the cells of the lower esophagus, where the normal esophageal cells essentially try to handle the acid exposure in a fashion that is not normal and can grow without any control, which can be detrimental to you and lead to cancer. Again, adenocarcinoma is the most common type in the U.S., and as I mentioned, GE junction cancers are a particular subtype of adenocarcinomas, which are found in the lower 2 inches of the esophagus and the upper 2 inches of the stomach. The reason why this is kind of separated out because these tend to have sometimes a little more aggressive behavior. When you have a cancer in a portion of the body, particularly the abdominal cavity, GE junction, so it can be upper stomach, there's a little more room for it to kind of spread to. So these tend to have a different type of pathophysiology and a different type of ability to spread to other places. So G junctions are a specific subtype and have to be handled with the appropriate care for sure. So some key facts and statistics. Esophageal cancer is more common in women. True or false? False, true. One of those. False. Yeah, esophageal cancer is actually more common in males. And we'll talk a little bit about some of that natural history of esophageal cancer. So, but first, the American Cancer Society does a great job. It's a great website, and it talks about all types of cancer. And it has what's very important are numbers and statistics on the prevalence, the incidence of different cancers. Talk about prognosis, survivability, survivorship. So certainly, American Cancer Society is a great initial resource to even discuss and look up any information about cancer in general. A great initial resource. So esophageal cancer, about 22,000 new esophageal cancer cases were diagnosed in 2024. So these are updated statistics from the beginning of 2025. Now, about 16,000 deaths from esophageal cancer, more commonly in men. Now, even with this information, it's not a very common cancer. Okay, overall, only about 1% of all cancers diagnosed in the U.S. are esophageal cancers. But when it does occur, it's very aggressive. More common among men than women. Overall rates in the U.S. have been stable over many years, and it's most commonly seen in Caucasians. And particularly amongst Caucasians, adenocarcinoma is the most common, most prevalent. Now, squamous cell cancers are more common in African Americans, okay? And as I mentioned earlier, 1% of all cancers diagnosed in the U.S. are esophageal cancers. So some risk factors. So this is very good. It's always good to know what risk factors you or may or may not possess, because with that information, knowledge is power. So if you know that you have a risk factor or many risk factors, then you probably need to go discuss further with your primary care provider and get in to see a GI doctor and potentially get some necessary procedures in order to help detect esophageal cancer early rather than much later. So some of the risk factors, risk factor essentially just means the increase in your risk for getting esophageal cancer, okay? Now, when you talk about risk factors, you can divide them in two as far as modifiable and non-modifiable. The modifiable ones are ones that you can particularly change. You can probably do something about. Non-modifiable ones are ones that maybe you were born with, or you can't control. Age, of course, family history, genetics. Can't do a whole lot about that. But the modifiable ones, I think if we can change some of those, you can certainly reduce your risk of getting esophageal cancer. So these are the ones we want to pay attention to for sure. But of course, if you have the non-modifiable ones, those are the ones where you probably need to seek out medical attention a lot sooner. You have a family history of esophageal cancer and a first-degree relative, maybe at age 40 or 50. You may have some genetic mutation that needs to be identified, and therefore you may need to be on a much more regular and frequent surveillance protocol. So diet certainly plays a role in esophageal cancer prevalence, particularly diets that are high in processed meats and also hot liquid ingestion. So this is something that is traditionally more associated with squamous cell cancer, something associated with typically in countries in the Eastern Hemisphere, who, particularly the hot liquid ingestion and foods, particularly meats and nitrates. And this is why worldwide squamous cell cancer is more prevalent in those parts of the country and more prevalent worldwide. Some genetic mutations that lend itself to have a higher incidence of esophageal cancer, tylosis and Plummer-Vinson syndrome. These are syndromes, genetic mutations associated with some skin changes, hardened, thickened, fibrotic, or scarred skin changes. Plummer-Vinson syndrome is a syndrome associated with iron deficiency anemia and swelling, particularly of the mouth and GI tract. But these are diagnosed very early in life. So you would know certainly by now if you had any of these genetic mutations. And then even something acquired, not genetic related, but acquired processes like lye ingestion. You were a kid and you had some Drano, and you drank some Drano accidentally because it was left out maybe. So you can certainly get caustic injury to the esophagus, which can ultimately lead to cancer much later on in life. And then HPV infection, human papillomavirus, the virus that's responsible for herpes infection, and other infections, but also can be seen in esophageal cancer development. And then this here is just kind of a table that discusses squamous cell cancer, adenocarcinoma, some of the increased risk factors, and then actual fold risk increase, which is nice to see sometimes. So if essentially squamous cell cancer more prevalent in older patients, 60 to 70s, achalasia is an esophageal dysmotility disorder where the esophagus is not squeezing and functioning as well. Very, very high risk if you have achalasia for developing squamous cell cancer. Smoking, 9-fold risk, very, very high. So this is a modifiable risk factor that if you were to stop smoking, you could potentially improve or decrease your risk of developing squamous cell cancer particularly. Alcohol use, 3 to 5 times fold risk. The African American race, 3-fold risk. And then moving on to adenocarcinoma, unfortunately, males, we don't have much to do about this. We can't do anything about this. We're already behind the 8 ball. 8-fold risk in developing adenocarcinoma. And then the Caucasian race, 5-fold risk. Reflux. This is why it's important to control reflux, particularly the acid exposure from reflux. So 5 to 7-fold risk for developing adenocarcinoma. Obesity, so BMI over 30 is a risk factor as well. Smoking, not as huge a risk factor for adenocarcinoma. Okay, it's more the reflux and the Barrett's esophagus, and as I mentioned earlier, Barrett's esophagus is a complication from uncontrolled acid reflux. Okay, so a little bit on diagnosis. What is the most common symptom of esophageal cancer? A, weight loss. B, difficulty swallowing. C, vomiting blood. Or D, chest pain. Well, it's actually difficulty swallowing. And, another word for it, or a medical term, is called dysphagia. You may have heard of it. And it's something, unfortunately, people will endure difficulty swallowing for quite some time. At first you think, hey, I just, I choked on my food, it went down the wrong way. And it continues to happen, and it becomes more frequent, and it's happening every time you have, a piece of meat, or happens every time you have bread, or every time you have, raw vegetables, and you don't think much of it. You get by with it. You drink, and then you wash it down. It starts to get worse over the coming months. Sooner or later, 4 months down the line, you've lost 15 pounds unintentionally, and you're struggling to even take. Your piece of chicken that you normally would scarf down in a heartbeat. That tends to be the norm, unfortunately. And not to say that every time you have difficulty swallowing, you have esophageal cancer. That's not what I'm trying to say. But it's something that you want to keep in mind, that if it's certainly not something that used to happen 20 years ago, and something that happened kind of all of a sudden, and it persists with different consistencies of food, and certainly you're starting to notice a little weight loss when you haven't, been working out as often as you normally would. Something else may be going on, okay? And that may be a time to at least discuss with your primary care provider. They may want to start with an X-ray or swallow study or CT scan. But that's when the wheels will start to turn. That maybe something else is going on, okay? Difficulty swallowing. All right, so just a little about some of the symptoms, some common ones and some not so common ones, but difficulty or painful swallowing with solids and maybe liquids. By the time it gets to liquids, it's certainly much more advanced. It's obstructing or blocking at least 2/3 of the lumen, that center portion of the esophagus. Chest pain, so you can have chest pain, and that can be just due to distension. When you take chicken or something, things get stuck a little bit, you start to have chest discomfort, your esophagus is expanding, so some chest discomfort, chest pressure or burning sensation. That could be from reflux, could be from this. Unintentional weight loss, okay, associated with any of these symptoms. Bing, light goes off, we need to get something checked out. Hoarse voice. That can be found in tumors that are much higher in the esophagus. Could mean involvement of certain structures outside of the esophagus, airway, particular nerve that controls the vocal cord. That can be much more advanced symptoms. Persistent cough, again, just right in front of or just anterior in front of the esophagus, the upper esophagus, is the trachea. And sometimes the tumor can invade the airway, the trachea. It's much more advanced. And it may present with a persistent cough. Regurgitation or vomiting of undigested food. We've probably all vomited before in the past, but usually the food should be digested. It's gone to the stomach, it's digested, and you vomit it up. Undigested food indicates that food never really got to the stomach. So there's some sort of blockage, obstruction. That can be the case in hyoid hernias as well, but that's something that usually develops a lot slower over time, or most people already know they had a hernia, and then the hernia got worse, and then it can develop into nausea and vomiting. This is much more, I should say, this is a symptom that kind of jumped up or occurred a lot faster. Vomiting or spitting out blood, as someone mentioned earlier, you're right, it's probably a little more advanced at that time, or a lot larger tumor. And then dark tarry stools, that's, you're bleeding, but it's going down instead of up. So some of the diagnostic workup, some tests that may be ordered, a barium swallow study, that's a test where you drink some contrast, they shoot some x-rays from the front and from the side, and that can detect whether or not your esophagus is open all the way, the lumen is open, or is there some sort of blockage or narrowing in any particular area that may help lead to an endoscopy or upper endoscopy or EGD. CT scan of the chest and abdomen, something that can be done with or without biopsy if they notice any suspicious lesions. A PET scan. Many of you may have heard of PET scan. It's really just a kind of a fancy CT scan, but they give you kind of a radio-labeled sugar in your IV, and it goes to parts of the body that use up a lot of energy, a lot of sugar. There are normal parts of the body that takes up this kind of dye, this sugar dye, and these are high-powered organs of the body. These organs use up a lot of energy, so they demand a lot of sugar, and that's brain, parts of the heart, sometimes parts of the kidney, and in the bladder because you're urinating that contrast. But there are 3 things that light up abnormally bright on a PET scan, okay? And those could be areas of infection, it can be areas of inflammation, and it can be areas of cancer. So typically in medicine, we want to rule out the most dangerous thing first before we say, hey, this is just an infection or inflammation. So typically if you see something that is abnormally bright on a PET scan, probably need to biopsy it, okay? And then prove that it's not cancer before going down a less aggressive pathway. And then MRI, not as commonly used, but can be used, depending on where the tumor is and what you're looking for. And then ultimately, the next step and the most common way of getting a diagnosis is through an endoscopy, upper endoscopy, or EGD they call it, esophageal gastroduodenoscopy. And then with that, the light in the camera goes down into the esophagus, they see an abnormality, they biopsy, you get the results back. If you do have a diagnosis of esophageal cancer, some of the staging workup may require something called an endoscopic ultrasound, EUS. And this is a special fancy upper endoscopy scope that has an ultrasound probe at the end. And the purpose of that is to get an idea of the depth of invasion. So remember I said the esophagus has many layers to it, many layers. The regular upper endoscopy scope can only see that one layer on the inside, that mucosa. But this fancy scope has an ultrasound probe which can pierce deeper into the walls of the esophagus and detect how deep does this cancer go. That helps with the staging. Is it just involving 2 layers? Is it involving 4 layers? Is it going all the way through and involving the liver and the heart or the spine? This test can help determine that, okay? And then they can biopsy, lymph nodes as well. They can look at lymph nodes to see if any concerning lymph nodes are there. This test is important for staging, usually. Unless you see something already metastatic in the PET scan, then the next step usually is an endoscopic ultrasound, usually. And then bronchoscopy sometimes, if you're going to bronchoscopy, then you're clearly concerned that the airway may be involved, which means this may be more advanced. So this is just showing some representative slides of what these imaging modalities may look like. So for A, thickening of the esophagus here, this is the upper esophagus. So trachea, windpipe is here in the black. Directly behind that, all the way behind that is the spine, white as bone. And then in between the two is our esophagus. So normally our esophagus would be here. This is not normal esophagus here. This is very thickened esophagus. This is concerning for a tumor here. So this is where I said that sometimes tumor can invade the trachea here, and then can also potentially invade the spine there. Just depends on how aggressive it is. And then this here is a PET scan of this similar cut, similar area, showing that this esophagus is very, very bright, unusually bright. Typically, the esophagus is not bright like this on a PET scan. This indicates some concern for malignancy. Now, could it be inflammation or even really bad reflux? It could be. Usually not this bright, usually not this high. But then you also have this here, which is a lymph node that is also very bright. So these two together indicates likely esophageal cancer with spread to a lymph node. And then this is just showing some other enlarged lymph nodes here, here. That's what that's showing. And this is just a CT scan showing some abnormal lung nodules here. 1, 2, 3, 4. We don't know that it's from esophageal cancer. This is esophagus here. This is trachea here. We don't know, but we see some abnormalities. So typically this will get biopsied. And if it is esophageal cancer, it'll say that in the biopsy results, okay? So just some imaging findings that you'll see on an upper endoscopy. Your provider may provide, after they do the procedure, give you a report of what they saw, which has some pictures. And this is something that they may see that would warrant a biopsy. So this here is what a kind of a squamous cell cancer would look, sometimes very flat. This is in the upper mid portion of the esophagus, and you can see how it's occupying kind of about 50% of the wall of the circumference of this esophageal lumen there. And then here are typical findings of an adenocarcinoma. It looks a little bit more angry, a little more nasty, has what they call exudate or mucus secretions around it because of the cells that it came from. And this is a typical appearance of esophageal adenocarcinoma here. Okay. So now staging. What is the importance of the stage for esophageal cancer? A, how advanced is the tumor? B, estimates the prognosis/survival. C, determines the treatment options. Or D, all of the above. Yeah. These questions are too easy. Yes, D, all of the above. So staging, when I usually talk to patients about any cancer, there are three, I always kind of use similar spiel to kind of explain this, to kind of give patients kind of an overview of how we view and look at cancer and how our mind is working as we see patients and as we go through the process, okay? And I'm going to give you a little glimpse of that here. So it really usually starts off with, we discuss all the findings so far with the scans and everything, the pathology, but then I kind of break it down. I have a little pamphlet or a sheet of paper I usually give patients. I usually start off with the first phase is diagnosis. When you see something abnormal, we want to diagnose it. Put a needle in it, biopsy it, get the answer. The next phase is staging. Now you want to know, how advanced is this tumor? Has the tumor spread anywhere? And sometimes you may need a few other studies in order to determine that. Some of the studies I've already mentioned, the CT scan, the PET scan, the endoscopic ultrasound, sometimes the MRI. Those are staging modalities that are important for us to answer this question as far as what is the stage of the tumor. And that's important because that ultimately helps determine your prognosis, your survivability, or your estimated 5-year survival. And then determines what the treatment options are, okay? And then after stage, which we'll talk about later, will be treatment. So, how does the tumor spread? How advanced is it? This can be very complicated and convoluted. A lot of technical terms associated with this. You guys may have seen or heard the TNM classification that's based off our American Joint Commission on Cancer, AJCC classification system that most tumors use. All types of tumors use this classification. And it can be different for each type of tumor, each tumor type. But that's what's used here for esophageal cancer. And really the T for that classification system really just stands for how far has this cancer grown into the esophageal wall. And that's where the ultrasound probe, the EUS, helps us determine the depth of invasion of the tumor into the wall of the esophagus. N really just stands for how many lymph nodes are involved. The more lymph nodes involved, the more the tumor spreads to different lymph nodes, the more advanced the tumor is, the higher the stage. And then M stands for metastasis. Has it spread to distant sites? And if the answer is yes, then this would be considered metastatic esophageal cancer, stage 4 disease, okay? So really just kind of a overview, stage 0 to stage 4. Stage 0 meaning the cancer is only within the epithelium, which is the very, very first layer of the esophagus. Okay, if you're gonna have this cancer, this is obviously the best place for it to be. And in stage 4, cancer has spread to other sites, distant sites, metastatic. And as I mentioned earlier, the stage is very, very important to determine your prognosis and also helps determine the treatment options. So just a kind of a picture diagram of what we're talking about here. This is an esophageal wall here, one wall. This is the lumen, this is the side here where the food and drink goes down. So this is the inner layer right here. So when I talk about the T stage, which is how deep has the cancer grown into the wall, we're talking about here, this is just high-grade dysplasia. This is what we call carcinoma in situ. The very first layer right there, this is a stage 0 right here. Very first layer, as long as no lymph nodes are involved or any metastatic sites, this is a stage 0. Then you got T1, 2, 3, 4. Just depends on how deep, how far we're going into the wall. This here, T4, means that it has invaded another nearby structure. So liver, spine, airway, that's T4. Now, lymph nodes, again, lymph nodes are found typically just outside the wall of the esophagus, but can also be found anywhere in the body. So N0 means no, we don't see any abnormal lymph nodes on the PET scan or on the endoscopic ultrasound. And N1, you usually typically 1 to 3, 2 lymph nodes, N2, 3 to 7, and N3 greater than 7. And then M just stands for any, no involvement of the liver, yes, involvement of the liver or other sites. And this is just kind of a more detailed view of what stage 0 to 4 is. So the treatment. Esophageal cancer can be removed without needing surgery at all. It can be removed, it can be eradicated, you could be potentially cured without needing surgery at all. It's actually true. And I heard someone mention radiation. That's a good thought. Typically, radiation alone is not a treatment for esophageal cancer. Typically, if you're going to do radiation, it usually involves some sort of IV treatment, chemotherapy, immunotherapy, so on. So it's not, at least not yet, a paradigm for treatment of esophageal cancer on its own. However, there are some endoscopic approaches that can be used, particularly to remove esophageal cancer, particularly if it's early, like a stage 0, that very, very superficial inner layer, if that's the only area involved, or even a T1 lesion, potentially, if it's small enough, can be removed endoscopically, actually. And that's something that's, I would say, is an advancement in the treatment of esophageal cancer, particularly on the GI side, as you have very skilled endoscopists who could, as long as it's less than 3 centimeters, hasn't invaded deeper than that T1 level, no lymph nodes involved, the PET scan doesn't show any evidence of disease elsewhere, which, again, that's very rare in esophageal cancer, but you can find patients every now and then that have that. Then you can potentially remove that area just by burning that inner layer, removing that endoscopically, and then you have to be under very, very close surveillance, Now, there is a risk of higher chance of recurrence with those, okay? Because you haven't really done anything to the lymph nodes, but the potential for a cure, potential. As you know, cancer doesn't always read the book. Cancer can spread to other parts of the body, be very, very small, and linger for a while without anyone detecting or noticing on imaging or anything else. But a few years later, it can start to grow. So those are the risks that can be associated with just doing that technique, okay? But as long as everyone is counseled and understands the risk, it is a way of potentially curing esophageal cancer if it's very, very early. That's why early detection is important. So treatment, there's several facets of treatment for esophageal cancer, and it's still changing, honestly. There's a lot of research going into treatment paradigms for esophageal cancer. Even in the past, I would say 5 to 7 years, we've gone through a couple of shifts, which is very exciting. Still a lot of work to do. Nothing is a slam dunk. But some exciting news coming out as far as how to treat it, particularly with immunotherapy, particularly with chemotherapy-only based treatments, particularly with combination of chemotherapy and surgery. There's a lot of information coming out about that. So it's very important, it's not saying that you will get it, hopefully you don't get it, but if you know anyone who gets it, it's very important to go to a place that has all the resources available to treat it, because it can be treated many, many different ways, okay? So first, typically, is a tumor board discussion, okay? And this is very important. When you have an illness, when you have an issue, you typically go to one provider. That one provider tells you what their thoughts are, gives you an assessment of what's going on. But it's quite possible that these things can be managed in many different ways. So it's important that, particularly with cancer, that you have a tumor board discussion. And this is really a panel of experts from medical oncology to radiation oncology to surgeons to pathologists, radiologists, and we all sit in like a conference room and we review the entire case, the images, the pathology. We kind of discuss and debate. We're arguing. We're going at it. And really, what we're trying to do is just what is the best case and scenario for this patient, and what's the next best step? What's the recommendation we are going to agree upon in a unified front to say, hey, this is the next best step for this patient, okay? And that's what it's for. And ultimately, that provider brings this back to you and said, hey, I discussed your case at a tumor board. There were 10 people there. It was the meeting of the minds. 2 heads better than one type thing, or 10 heads better than one. And this is what we think, okay? There may be something that I don't think about, something that you may know that I didn't know, and therefore we can come up with the best recommendation for this particular patient, okay? So tumor board discussions are important. And then based on several factors as far as the treatment, stage is the most important factor. As I mentioned, advanced stage tumors, stage 4 tumors, typically are only treated with IV therapy. The anatomy of the tumor, meaning is it resectable versus unresectable? So it depends on what's involved, what's invading. Typically, if it's involved in the trachea, this is an unresectable tumor. Not going to be able to remove part of the trachea, the airway, and still survive. So this determines our ability to resect it and remove it. So that's important to know which can then determine what your treatment will be. If I say, hey, this is unresectable, then we're going to go down a different paradigm. Versus this is resectable, then we're going down another route. And then the patient's overall health, okay? I mean, let's face it, patients who are very, very sick, have multiple medical problems, probably not going to be a good candidate for surgery. That may diminish your overall quality of life and maybe too much for your body to handle. Patients' willingness and essentially goals for treatments. I've had a few patients, whether it's lung cancer or chest tumor or whatever, you may be 90 years old and say, hey doc, I've lived a great life. I don't want any treatment. I think that's reasonable. So it's my job to respect that and get you the resources you need to maintain your quality of life, okay? And then several modalities I mentioned earlier. Endoscopic approach is one approach for very early stage tumors where you don't need any surgical treatment, you don't need any radiation, you don't need any chemo typically, as long as it meets the specific criteria. Surgical resection is a very, very common route to go, very common. And then there's radiation, and there's chemotherapy, immunotherapy, targeted therapy. Radiation typically is not done alone, typically done in conjunction with some sort of IV or bodily systemic treatment here, okay? Surgical resection sometimes can be done alone. It used to be done more commonly 20, 30 years ago. The outcomes were not as good, so typically it's combined with chemotherapy or combined with radiation and chemotherapy. And this is just breaking down the stages here. So early stage tumors, like I mentioned, endoscopic resection. You have to make sure your margins are negative and no lymph nodes involved, but these do have a higher chance of recurrence of the cancer. So need routine surveillance and imaging. Patients in this group also can undergo surgical resection. Sometimes much younger patients. I've had 40, 50-year-old patients who have an estimated 30, 40 years left of life. Sometimes it's better to go with the surgical resection and avoid the chances of a spread of cancer. Intermediate stage tumors, like stage 2 or 3 tumors, typically involve surgery with some sort of chemo or surgery with chemoradiation. And I mentioned earlier a newer paradigm where it's only chemotherapy combined with surgery, no radiation needed at all. This is a newer paradigm approach and works actually quite well, works very well actually, but can be more aggressive on the body. The chemo can be aggressive, and there can be several side effects associated with the chemo. And then some patients who are not surgical candidates, probably just best to go definitive chemotherapy with radiation. And then for stage 4 tumors, typically just only IV or systemic treatment is required, chemo, immuno, or targeted hormonal therapy. So just briefly on the surgery, esophagectomy is a preferred treatment for those patients with local disease, just focal in that one area, and maybe involving some lymph nodes around that area. And typically here, you can see this esophageal cancer in the lower to mid esophagus here. This involves typically removal of this portion of the esophagus, as well as sometimes a small portion of the stomach, particularly where it depends on where the tumor is. And then we reconstruct it, meaning we pull the stomach up. It's called a gastric pull-through. So essentially we tumorize the stomach, make the stomach into like a tube, new esophagus, and we pull that up to connect to the remaining esophagus. Sometimes in the chest, sometimes in the neck. That's esophagectomy. It's a big operation, but can reconstruct the GI tract, particularly in patients who are not able to eat or drink at all. They may be tube feed dependent, can be able to eat and drink afterwards. There's so many lifestyle changes associated with it, which we have to discuss beforehand to determine if that's the route you'd like to go. When you talk about survival, esophageal cancer is an aggressive tumor, rare and aggressive. In the 1980s, 5-year survival used to be 5% or less. Now, we've improved through research, through different surgical techniques, through paradigm shifts as far as chemotherapy, immunotherapy addition, and even targeted hormonal therapy. Now it's closer to 21%. Still not great, but better. There's still a lot of work left to do. When you talk about earlier stage diseases, especially patients that get surgery, survival can be closer to 40%. So this is a combination of likely chemotherapy with or without radiation and surgery. You can get survival rates of up to 40%. okay? And then probably even better now with immunotherapy. This is even without immunotherapy. So with immunotherapy, probably even higher, closer to 50%. Still may not sound great, but certainly better than 5% or 20%. So some advancements, as I mentioned earlier, some advancement in surgical technique, which includes the anastomosis, which is the connection between the stomach and the esophagus. And then also the robotic platform, very, very cool platform, which I'll bring up a little bit later. And then just a little bit about the systemic treatments, as I mentioned before, just depends on perioperative chemotherapy and then the use of hormonal treatment and immunotherapy. So traditionally, thoracic surgery has always been considered maximally invasive surgery, meaning we make big incisions, we do big resections, and patients are left with a lot of pain and discomfort and obviously big changes in their quality of life. For instance, this here is a sternotomy, still a very common procedure done today, particularly for heart-related illnesses. We obviously make an incision there, cut through the bone, and remove whatever we need to remove, or do a heart bypass surgery, and this is the incision that's left afterwards. This is a classic way of doing esophagectomies. I even did these, 15 years ago. This is an esophagectomy. Big incision in the belly, big incision in the neck, and it's called a transhiatal approach. You get almost your elbow in the chest on one side, and you got your finger in the neck there, and you're just trying to bluntly dissecting and freeing up the esophagus, getting some lymph nodes, and that's called a transhiatal esophagectomy. Okay, still done, and still effective, but maximally invasive. This is another diagram of a maximally invasive surgery, a thoracotomy, a left-sided approach. They went through between the ribs on this side, left side. This is how the patient was positioned on the table on their side in order to make this incision. This is the incision here, and they have a kind of like a rubber band around the esophagus here, and they're trying to free up and dissect out the esophagus to do that work. This is diaphragm right here, right there. So this is a maximally invasive surgery. So the thought was, you either go big or you go home. So a dog prefers a very big stick there. And that was the thought, okay? However, we discovered, 20, maybe over 30 years ago, but not used as much at that time. There were better ways, other better ways. And then we're talking about some advances here. So minimally invasive operations. So doing what we call a VATS, or video-assisted thoracoscopic surgery, or RATS, robotic-assisted thoracoscopic surgery. These are incisions that are much smaller. We're using a light and a camera to see. You still see inside the chest cavity. As particularly the robotic platform is 10x magnification. Okay, so you can see probably better than you could if you had an open operation, actually. But you're using smaller instruments or smaller incisions. You're using instruments that can get in there and do what your fingers were doing before. Okay, so the VATS approach, which is video-assisted thoracoscopic surgery, typically using kind of straight sticks, so a little more limited. These are just long, straight instruments. Doesn't have much flexibility or rotation ability to them. But this was the initial iteration of minimally invasive surgery, still done today and done quite well and very, very often. And this is just someone doing a lump surgery with that. But these are some of the incisions that are marked out there. These tend to have reduced pain scores for these patients, so no rib spreading, no rib cutting, not significant muscle cutting, decreased length of stay in the hospital, less blood loss, and quicker time to recovery overall. These are some incisions for a video-assisted surgery, so VATS incisions outlined here. Here again, using the straight sticks or straight instruments, and this is the healing. Then we talk about robotics. So this is just when you're talking about esophagectomy, as I mentioned, I showed you the old school way or the open way where you make a big incision in the belly, a big incision here. So still have to go through two fields. So esophagectomy, your incisions here in the belly, incisions in the right chest, but these are much smaller incisions, 5 and 10 millimeter incisions, 5 and 10 millimeter incisions here. And this is the healing process. After a while, you won't notice the incisions, you won't notice the scar. So you're comparing a thoracotomy, right-sided big incision here, with those stitches there, to someone healing with smaller incisions here. Robotics, this is where I specialize. This is what I specialize in. I enjoy robotic surgery. As I mentioned, it has a lot of advantages for patients, a lot of advantages. One advantage here is you see the wrist. If you move your wristed motion, you have a lot of flexibility. You can get to many different aspects just by keeping your arm here and moving your wrist like this. You have a great ability to get to many different crevices. And that's what the robotic instruments provides for us. It is wristed motion in any direction. Different from the straight sticks, the video-assisted thoracotomy, where you just have one direction and limited rotational ability. This is amazing. This emulates a human wrist, and even more so, actually. And we have the ability to get to any part of the body or the chest cavity or the belly cavity with it. Here is just showing the different arms. Actually, some robots have 3. This one has 3, but the common one that we use has 4 arms. So I can control 4 arms when I only have 2 arms of my own. So this allows the ability for me to have much more control in the operation. Ability for me to control every single aspect of the operation, which I feel will be safer for the patient as opposed to relying on someone else to do something else for me. We still have an assistant at the bedside who can help exchange instruments, give me the needle, the sutures, remove devices or specimens or the cancer out of the body, while I am here at the console doing the work of controlling the instruments, okay? So it's not the robot doing the surgery, I am controlling the robot and I'm doing the surgery, okay? So this, as well as just showing the ergonomic capacity for the surgeon console here. This allows for obviously great posture, great visualization through this console, and longevity of your surgeon. If he's a great surgeon or she's a great surgeon, she will be continue to do what she's doing and do it for a very long time. So this is the newest baby within the robotics platform. This is called the DV5. We have one of these at Boswell, and also even at Del Webb. This is beautiful. So this is, a much sleeker profile, a lot more capabilities. This is also a sleeker patient profile with the arms, a lot more technology associated with it. These 2 devices here, a lot more technology, video capabilities, learning capabilities, AI injected within it as well too, ability to even suggest more efficient moves for the surgeon, ability for the surgeon to review their operation and learn from their own operations. What could they have done better? What went wrong? What happened? Ability for you to rewind. Say you lost a needle somewhere, you can rewind and say, hey, the needle went there. This is awesome. This is awesome. So all of this is really just improving the ability for the surgeons to do the work, to do it faster, and for the patients to get the better results, okay? With minimal pain, quicker time for recovery. This here is a game changer, not just for esophageal cancer, esophageal surgery, but for lung surgery, for any surgery. This is a game changer. And this is at both hospitals, okay? And this is just a little bit of pros and cons as I kind of discussed as I was going through thoracotomy, which is the big incision, versus the video procedure versus the robotics. Robotics providing a lot more advantages as far as the ability to get to areas, great visualization with a 10x magnification, the wristed motion of the instruments, better pain control, shorter hospital stay. And in summary, just some final points in my last slide here. This is some things I want you to know and remember. Esophageal cancer is a rare aggressive tumor, okay? More common in Caucasians, more common in males. Dysphagia or trouble swallowing is the most common symptom. It's most common, but it lingers the longest. People don't think much about it until it gets really, really bad, and that's usually after a few months, and they've lost a significant amount of weight. Seek medical attention early to have the best chance of cure and survival. Most patients require systemic therapy. Most patients. I will tell you, most patients, by the time they see us as a surgeon in the clinic, about 50% of patients already have metastatic disease. It's unfortunate, but that's the reality. It's lingered for quite some time for the patient at home, and then they go to the primary care provider, then they're referred to GI doctor, and they finally get scheduled for a scope, and then they finally get the diagnosis, then they go to a medical oncologist does the PET scan and other tests, then they finally come to us, and at that time, it's probably much more advanced. So unfortunately, detection early is key. Regardless, most patients we see, they still require some sort of systemic treatments, even if they are a surgical candidate, particularly if they're in stage 2, 3. And then surgery helps increase and improve survival rates. Chemotherapy alone, even chemotherapy with radiation, typically only about 20 to 30%, or 20 to 25% eradication of the tumor. With the addition of surgery, typically we can get that up another 20%, okay? So surgery typically helps with increase and improved survival rates. And then advancements in surgical techniques and approaches have improved patients' ability to tolerate the procedure and quality of life. You know, with the much larger, bigger incisions, certainly long time for recovery, poor quality of life for months before they start to turn around. This has improved greatly the ability for patients to recover and improve their quality of life after surgery. Thank you. I know I took quite a bit of time, I apologize, but I would like to open the floor for questions. Yes.
Okay, I have acid reflux. I very seldom have surgication, but I know after I eat, I cannot bend over to pick up something on the floor. I don't want to do that.
Because it'll reflux up or regurgitate up? Yeah.
Right. Now, I do take omeprazole. I sure don't like what I read about it. Is that the best thing to take, or is there something else?
Yeah. You know, certainly as we discussed earlier, acid reflux certainly is a risk factor. You know, acid reflux can occur on its own, meaning it could be primary acid reflux. But acid reflux, the actually most common cause of acid reflux is an associated hernia with it. Hiatal hernia is the most common cause of acid reflux. So, you know, I would say about 50% or 50 to 60% of Americans have acid reflux and or a hiatal hernia. It's actually a very common diagnosis, very common. But most patients are able to live with it and manage it with, you know, diet changes, lifestyle changes, modifications, exercise, watching what you're eating. You can control the symptoms, particularly the acid reflux symptoms. And if that doesn't work, then you chew on some Tums, then you go to, you know, like a Pepsid. And then if that doesn't work, then you go to something like omeprazole, a PPI, proton pump inhibitor, omeprazole, a pantoprazole, a Prevacid, something in that class. But all still reasonable approaches to managing reflux, okay? If your symptoms are controlled with all those changes, then there's really nothing else you should do, okay? Typically. So omeprazole is a good drug for it, as long as it's controlling your symptoms, which typically the symptoms you refer to usually are like the heartburn. Yes, certainly when you lean over, you may have regurgitation. That can be the case with or without the medication. But, so that's just more of a lifestyle change you'll have to make in order to not lean over or lay down flat and go to bed too soon after eating or drinking, okay? But largely the symptoms are, it sounds like they may be controlled still, the reflux, the heartburn. And if that's the case, then I suggest you stick with it. If it's not controlled, you can always change. Sometimes we go through 2 or 3 changes in the medications to get to the optimal medication and dose for you. Now, when those things don't work, and you've tried the medications, or you're having worsening symptoms despite the medications, or you're starting to have some nausea and vomiting, or you're having bleeding issues, that's when patients come and see surgeons, okay? So it's not common to actually operate on these conditions given the prevalence in America. Most people don't need an operation. It's just when those meds aren't working or your symptoms are worsening, or sometimes people have complications. So sometimes somebody has really bad osteoporosis, then the PPIs unfortunately can worsen your osteoporosis. Sometimes patients who have really bad kidney disease and they're trying to avoid getting to stage 5 kidney disease and needing dialysis, sometimes the PPIs can affect the kidneys too. So those are some reasons to seek surgical attention even though the meds were working. Okay. Does that make sense to answer your question?
Yes.
Okay. Yes, sir.
Is that available on the website?
The slides, I think it'll be available.
Yeah, we're creating a video of this, and we'll, Dr. Wakwe, if you'll give us your slides, we're going to incorporate the video, and it'll all be available online through
Some
us.
people weren't able to come, so.
Sure.
Yes.
And you have business cards.
I'm sorry. Okay.
We'll share his contact information.
I'm going to Instaprint right now.
Okay, no, I'm sorry. I may have one. If you want to make comment, yeah. Yeah, I do have some actually, yeah.
There is a slide with your contact information after this one.
Okay, perfect. Thank you. Appreciate it. Yes, ma'am.
I was going to say, one of the things that sometimes I notice is you're not going to come to you when you have the initial symptoms. You'll go to your GI and they'll do the tests, and they'll probably do the endoscopy and maybe say, well, I can go in and I can get this out. But at what point, I know sometimes physicians have a tendency to kind of cross over that fine line and say, well, I could do this, I could do this. In the meantime, time is wasting for you when it's like you want to say, stop, I'm going to go see Dr. WW.
Yeah, no, good question actually. This is a challenging.
It's always good to have one in the clinic.
Oh, sorry. This is a challenging topic, particularly for me because I've been here about 5 years, and one of the things you'll find here in Phoenix and could be anywhere, there's a lot of we have a lot of like medical pockets, a lot of providers everywhere throughout Phoenix or Greater Phoenix, and a lot of pockets, but there's not a lot of crosstalk. So it can be very difficult with the communication between different providers, different specialties. And it's been tough, I think. And really, I think it's going to take advocacy for both the patients and the providers. Okay, so what I mean by that is, for me, I've gone to several, offices, GI offices, medical oncology offices, radiation oncology offices, and really just kind of discuss really not just the role of surgery for the conditions that they manage, but also kind of the multidisciplinary approach to the conditions, okay? It's quite often patients will go from GI doctor to medical oncology and then go through, chemotherapy, radiation, but never even visit with a surgeon. Not to say that you will have surgery. It's not necessarily, hey, I'm sending you to the surgeon to have surgery, but I think it's certainly important to know your options. And surgery is an option. And therefore, it should be a multidisciplinary approach between a discussion between the medical oncologist, the radiation oncologist, and the surgeon. And then together we discuss, hey, what do we think is the best option or the best route for this particular patient? And that's what I'm trying to change, the paradigm shift amongst the providers from my side is, hey, I think patients deserve a discussion about what their options are, surgery being one of them, give my spiel, but ultimately give you the information to empower you to make a decision about your care, okay? And then if the decision is to go just chemo radiation, then fine, I think that's reasonable, but at least you know your options. What can happen sometimes, a patient goes through chemo and radiation and then comes to a surgeon later, and I really can't do anything about it. And particularly if the radiation is given in a certain fashion, in a certain area, then it makes the patient unresectable. So you can lose the option of potentially having surgery if maybe all I had was a conversation with the radiation oncologist, say, hey, you can do radiation, but only give to this amount, only give to this area, still makes my job possible. So that's kind of the crosstalk that's necessary. Then on the patient front, I think coming to something like this, knowing what your options are, and knowing that medical oncology, radiation oncology, and surgery should be in on your care before making a decision. And it's really just about patients understanding their options, what's possible. Sometimes you don't know, and you're just at the mercy of who you saw first, okay? So, I think just doing more of these things to educate the community about the options so that when they go to see the provider, they can be their own advocate as well. Say, hey, thank you for the information. I'll go see this guy, but I also want you to send me to, a medical oncologist or a radiation oncologist or a surgeon. I want to have the discussion with multiple providers so that I can make a decision best for me. So I think there's no better way, I think, besides the patient and providers being advocates. Yes.
Any other questions?
I have a,
Yes, ma'am.
so my father-in-law had throat cancer, so seeing all those facts, I was like, oh my gosh, like everything was pretty much spot on. Question is, life afterwards. So he did no surgery, chemo, radiation, but the radiation did a lot of damage. So are there advancement in treatment for kind of those things? Like he has an issue now where he can't lift up his head because there's a disc that's dislodged, but they can't do surgery. They're not recommending surgery because there's a lot of scar tissue from the radiation. And because he has no saliva glands, he continually has to go and have a balloon to
get stretched.
Yeah, to get stretched. So are there advances in those types of things for life after?
Yeah, no, good question. So it sounds like you're talking about head and neck cancer, and that's, it's similar to esophageal cancer, but much, much higher. And his treatment was primarily non-surgical treatment. So therefore, you get much higher doses of radiation, which is something that should be explained prior to going through that. And because of the higher doses of radiation, the complication risk profile is much higher. Radiation can do a good job in controlling and eradicating a tumor, but it's very non-specific, meaning they try to focus on an area, but you have usually some surrounding collateral damage. And unfortunately, when you radiate that area, particularly the esophagus to that degree, it can obstruct, it can occlude. So typically at that point, I'm not aware of many quality of life improvement maneuvers besides what you're talking about, dilating the esophagus, or even, if he's tired of that, having to get a permanent feeding tube to bypass the esophagus. Now, when you talk about patients who've undergone surgery, typically the risk profile from chemo and radiation is a lot less because they get less of that overall up front, or even around that period. They're just getting enough to sensitize the tumor, to keep the tumor controlled, and to give us an idea of, is this tumor too aggressive? The tumor grows through chemo and radiation, then surgery probably won't be helpful for the patient. So it's more of it gives us an idea of how aggressive the tumor is. If the tumor is controlled with chemo and radiation, then this patient probably could be a good surgical candidate, because if we remove that tumor, then they probably will have good control everywhere else. So you get less of that if the plan is surgery, which is why I mentioned it's important that you see a surgeon, because if you get high doses of chemo and radiation, then surgery is probably not going to be possible for you. So it must be known up front so that they can regulate the amounts that you get. So when getting surgery, typically those complication profiles are not present. You may have a different complication profile, but not such as that. Most people are still able to eat and drink afterwards because we've opened things up. We've taken out the tumor, which was blocking the esophagus, and so on and so forth. Now, for what you're talking about, the best thing is the dilation, unfortunately.
Thank you.
Yeah, amazing stuff. All right, I'm going to see if I can manage this on my own. Maybe not. It's not advancing.
Oh, it might be the wrong.
It's this one. We have multiples. Yay! Now we have the contact information up there. I love these talks for just the reasons that you heard, is all of us either are involved with this or have our own personal experience with this, and having access to physicians like Dr. Wakwe is really our gift to the community. But that's not going to go without a pitch, which is, I think you saw the equipment he talked about and said that was such a game changer. That really came through Sun Health's donors. So all of you, and it was huge. It was a lot of money. Those robots are like $1 million each, each one, and they really are game changers. And it's really important for all of us to build the community of healthcare. And I will say, that's sort of intimidating. We're certainly not expecting anyone to write us a check today. But most of our gifts come through estate gifts. They're bequests, because a lot of us need to live on our resources. But you can really leave a legacy, and you can do it through Sun Health. Support people like Dr. Wakwe and the community of the future through all of this, so that we'll all have access to this amazing quality care moving forward. So if there's any way you'd like to learn more about supporting the Sun Health Foundation and their work and doing more of what you saw up here today, please get in touch with us, because we'd love to engage with you. We do a lot of other stuff, by the way, including scholarships for healthcare workers. A lot of the nurses at the 2 hospitals come through our scholarship program. And so we're really trying to build this community of healthcare throughout the West Valley. If you'd like to contact any of us, I know you'd rather talk to Dr. Wakwe, but you're welcome to talk to us at the foundation to learn more about programs that we have coming up. Generally, we offer almost everything free to the public. And that's because of donors that have supported us over our 60 years. So with that, thanks to all of you for coming out today. And please give us your feedback on what else you'd like to hear about, where else you'd like for us to present, and we'll look forward to seeing you again soon. Thank you.
To learn more about Sun Health Foundation initiatives, become a donor, or attend a future Coffee Connections event live, please visit us online at sunhealthfoundation.org or call 623-471-8500. Sun Health, empowering people to live longer, healthier, and more purposeful lives.